Welcome everyone to today's webinar, Diagnosis and Treatment of Inflammatory Breast Cancer, led by Dr. Lintz. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the IBC team for this partnership. If you have any questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource-center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the webinar to Dr. Lintz.
Thank you, Sierra. Hello, everybody. It is my real pleasure to be with you here today to tell you about diagnosis and treatment of inflammatory breast cancer. This is a slide from our website where we try to go over how one can be diagnosed with inflammatory breast cancer. As many of you know, inflammatory breast cancer is a rare but unfortunately aggressive form of breast cancer. And what is unique about inflammatory breast cancer, that from now on I will call IBC, is that often it is not detected by a mass or lump in the breast, but it's instead diagnosed based on the clinical findings, the skin changes, together with the diagnosis of invasive breast cancer. What is also unique about this diagnosis is that the findings usually come up very quick, less than 6 months, and often within 1 or 2 months. You can see here in this cartoon what the clinical criteria of IBC include. That goes from redness of the breast to breast swelling, enlargement, pain, itchiness, thickening of the skin, and swelling of the lymph nodes. A patient does not need to have all these symptoms to have a diagnosis of IBC, but often has more than one. So just to give you a little bit of a historical perspective, back in the 1814, Sir Charles Bell was the first one to have a description of this rare form of breast cancer that was associated with a poor prognosis. And the way he described was when a purple color is on the skin over the tumor, accompanied by shooting pains. About 70 years later, there was Thomas Bryant described dermal lymphatic invasion as a cause for these unique skin findings. And later on, 2 investigators of what is today Memorial Sloan Kettering proposed the use of the term inflammatory breast cancer. So to go back to the diagnosis of inflammatory breast cancer, it lacks a specific histological and molecular subtype, meaning you can have IBC that is hormone receptor positive or HER2 positive or triple negative. You can have IBC that it's ductal in terms of histology, and that's the most common subtype, but you can also have invasive lobular carcinoma that presents as IBC. As we mentioned, the diagnosis is based on clinical findings, and I've listed those here for you. You can see on the right some examples of photos of patients that presented with inflammatory breast cancer. There is, as I mentioned, variation in clinical presentation, but most of the times patients have at least a few of these clinical findings, and the clinical hallmark is the rapid onset of these signs and symptoms. There are some unique presentations in terms of the diagnostic imaging as well. Often you cannot identify a mass in the mammogram, or even, in other modalities, in other imaging modalities. But what is unique, and that's what tries to be represented here, is the edema, the thickening of the skin. Dermal lymphatic involvements, as we learned, that was one of the first findings described and associated with inflammatory breast cancer. This is present in about 75% of the cases of inflammatory breast cancer. However, and this is never enough to reinforce that a patient that has dermal lymphatic invasion and does not have the other typical findings does not necessarily have inflammatory breast cancer, and the other way around is true as well. A patient that has all the typical findings but lacks dermal lymphatic invasion on a biopsy that does not exclude a diagnosis of inflammatory breast cancer. So this helps making or excluding the diagnosis, but it's not a criteria that on its own makes or excludes a diagnosis of inflammatory breast cancer. And why does it matter? And we will get back to this again during this presentation. Why does it matter to make the proper diagnosis of IBC? So one of the reasons is because historically, and that's what it's represented on this slide, we have seen that patients that have inflammatory breast cancer do worse than patients diagnosed with LABC, which means locally advanced breast cancer, that are patients that have a breast cancer that often also has skin findings, but that was present for a longer period of time. And patients with inflammatory breast cancer and locally advanced breast cancer do worse as well than patients that have other stages of breast cancer that are not metastatic, but are not T4, or meaning locally advanced or inflammatory breast cancer. And that's what you can see here on your left. The patients diagnosed with inflammatory breast cancer are represented here by the curve with the white dots compared to the curve with the black dots, or to that it's the locally advanced breast cancer, or the patients with the black triangles that are the ones that do better from these three categories. So we want to identify the patients that have inflammatory breast cancer to offer them the best treatment options to try to improve how they'll do as much as possible. Okay, so this is something that many of you might have heard about, that the trimodality therapy is the mainstay of treatment for inflammatory breast cancer. What does it mean, trimodality therapy? Well, it includes some sort of systemic treatments before surgery that we call neoadjuvant therapy, here highlighted in the first box, followed by surgery, that in the vast majority of the cases will be a mastectomy with axillary lymph node dissection, followed by radiation to the chest wall and regional lymph nodes. This is what we call the trimodality therapy. And in most of the cases, there will be some additional treatment after completing radiation. Why is this important? We have learned from different studies that the patients who receive trimodality therapy, here on your right represented in blue, they do better than the patients that only receive two of these treatment modalities, here represented in yellow or red, or even better than those that only receive surgery, represented in gray. So we want to make sure that all patients diagnosed with inflammatory breast cancer are offered trimodality therapy. This is something of concern. This is data we presented last year at ASCO, showing that over time, less patients are receiving or are being offered trimodality therapy, patients with inflammatory breast cancer, and we are working to try to understand why that might be the case. So also important to make the proper diagnosis of inflammatory breast cancer, because we know that patients with inflammatory breast cancer more often present with distant metastases, meaning with stage 4 diagnosis at initial diagnosis, and we want to be aware of it and not miss this diagnosis. So in summary, I try to include in these slides what are some of the current challenges in the diagnosis and treatment of inflammatory breast cancer, which are ambiguity in the diagnosis, and I showed you some examples and how we can make the diagnosis. The diagnosis depends on the experience of a provider with these cases. It's important to make appropriate and adequate treatment plans, and the research in inflammatory breast cancer that we need to move the field forward can be affected if we are not clear about who has this diagnosis of IBC. So I wanted to tell you about a proposed scoring system that is currently undergoing validation and that we hope that will improve the diagnosis of inflammatory breast cancer. So years ago, an IBC task force was brought together by the Inflammatory Breast Cancer Research Foundation, the Milburn Foundation, and Susan G. Komen. And what these IBC experts did was to review different features that are associated with the diagnosis. You can see here a list of these features and how they were given different priority factors according to their importance in making the diagnosis. And something important as well is part of the manuscript that highlights how these diagnostic criteria were developed. There are photos as well highlighting different skin tones and how the findings can be different for each different patient. Why is this important? We feel that if we are able to refine the diagnostic criteria associated with inflammatory breast cancer, we'll be able to decrease subjectivity, allow better patient identification, allowing patients to be included in clinical trials, and make sure that trimodality therapy, as we went over that a little bit ago, is offered to all the patients that meet criteria for inflammatory breast cancer. So I wanted to end by showing you some of the clinical trials that are currently being offered at Dana-Farber. We have TRUDY and NeoStar Arm C. These are two clinical trials for patients with stage 3 inflammatory breast cancer, where we are offering antibody drug conjugates that are approved in the metastatic setting, but patients with inflammatory breast cancer that meet criteria for clinical trial, for these specific clinical trials, will have an opportunity to be treated with these agents in stage 3. We are also enrolling patients on a registry that is trying to learn what is the impact of the trimodality therapy for patients who have stage 4 disease. And we are also trying to learn if there is an opportunity to do less axillary surgery in patients with inflammatory breast cancer. So if you are diagnosed with IBC, or if you know of anybody diagnosed with IBC, and they are interested in clinical trials and registry participation, we are happy to meet with any patient with inflammatory breast cancer and tell them more about these clinical trial options. And here is a list of the key people in our IBC program and contacts on how you can reach out to us if you'd like to come for a consultation. It takes a village to put all these resources and clinical trials together. And that's why I wanted to highlight Dr. Naklis, our Associate Director of the program, Ryan Tamargo, our nurse practitioner, Marisa Powell, our program administrator, and Elizabeth Troll, our IBC Clinical Research Coordinator. Thank you all for your attention.
Thank you so much, Dr. Lintz, for this informative and important presentation on inflammatory breast cancer.